for the Department of Health. Guys, have a look at these. Look at these numbers. 14 million tests, 1.138 new HIV positive patients. And then they want to put 805,000 onto ARVs, which means they're not meeting the 90-90-90 targets. You all know that we should be getting 90% of people that are HIV positive onto ARV treatment, and 90% of them need to be virally controlled. So, let's have a look at the city of Joburg. And apologies to my clicks, I don't have your geomap. You'll have to give me your geomap. But I'm just giving you an example here of ICPA. So here's the district of Joburg, population of 5 million that we know of. There's the positivity ratio, there's the target for the tests, 139,000 new HIV people. There are 312 ICPA pharmacies just in that area. And what I can tell you is that there are over 1,000 pharmacies in Gauteng, 1,000 points. Now, if any of you know the clinics in the CBD, Joburg Central, you'll know that those clinics are absolutely overburdened. Now, if we say to those clinics, here are another 1,000 entry points to treat that 100,000 people. Well, what I can tell you is I have presented this to the Minister of Health, and he wants to know when we're starting. So, there's just to show you the number of extra primary health care points of contact that pharmacy can bring. So HIV and pharmacy, I don't need to tell pharmacists what we already do. We do all these things. We've always been able to test. We can even confirm a test with a second rapid diagnostic. You'll know you don't have to do the ELISA anymore. We dispense ARVs. We are an underutilized or badly utilized resource. We're overworked giving parcels of medicines out, and we're not using our clinical care. There's an opportunity here to reach the untested and untreated populace. A lot of us have got nurses, and we know that the legislation is enabling. So, how can we help? Wide footprint, extended trading hours, a large pool of healthcare professionals, established logistics and supply lines, advanced information services. A lot of government departments are still writing on packets. Most of us, and I would say 98% of us, have got electronic systems where we have proper patient records. We are regularly inspected by Pharmacy Council. You'll know, grade C every year, grade B every 2 years, grade A every 3 years. We've got clinics already offering point-of-care diagnostics and monitoring. And obviously we have ARVs. So what are these unique opportunities? And this is what USAID or USAID was so interested in, is that why would pharmacy help the South African government get to the 90-90-90 targets? And here are the reasons. Currently, through retail pharmacy, we are dispensing 100,000 morning after pills every single month. That's 200,000 cases of unprotected sex, unless people just like taking the emergency pill. Maybe they all think Plan B is a good idea, I don't know. We do family planning. We have well baby clinics. Minor ailments. We have men coming in for sports supplements. They don't go to clinics because they think clinics are for women and babies. We've got men coming in for Viagra, for libidos, for Maximor. We've got men coming in with hangovers, and ladies. I don't want to pick on the men here, but it's the men that are not getting tested and treated. We do wellness screening. We do screening for HIV. We do national campaigns. And the pharmacy I was at, all the waiters at a particular restaurant in our mall all seemed to be diabetics because they were all buying needles from me. So we've got an opportunity with the drug addicts. I don't know if you've seen those horrible videos about Bluetooth. So I hope none of you are doing Bluetoothing. Right, so what is pharmacy-initiated management of ARVs, or PIMART? The idea here is that we develop best practice clinical guidelines for pharmacists and pharmacy-based nurses. They will be informed by global HIV experts and research. We're going to develop high quality training on NIMART and PIMART. We're going to bring on pharmacies across South Africa. We will provide online support to newly trained pharmacists and pharmacy nurses, including real-time guidance from experts. And that's Vula Mobile. I don't know if you've heard about Vula Mobile. We'll have a customized digital platform so that patients can migrate between branches, between provinces. Their records will follow them. And we will market the availability of these new services to the public, to the target markets. So those are the objectives, and I think we can all understand the objective is to establish an accredited pharmacy network that can safely and effectively expand access to HIV screening, prevention, treatment, and care. How are we going to look at the eligibility? So the idea here is that through PIMART, we identify people that are negative. And if they have had unprotected sex and they need PEP, we could give, was it sexual assault or just a late night and a one night stand, we can give them PEP. If it is somebody that are not, they're not going to change the way they're living, we can put them onto PrEP. We have to keep our negatives negative. Then if we have a look at the HIV positive people, the idea is that we will be able to institute first-line therapy in adults. We're going in carefully. We're not going to try and treat children at the moment. Let's go one step at a time. So in fact, the number of young children that are HIV positive is decreasing now with ARV treatment and that prevention of mother-to-child transmission. So we would be looking at over 15 years old. We would be testing HIV. They would have to test HIV positive, have a CD4 count greater than 200. We do not want to be handling people with a CD4 below 200 cells because you can unmask all sorts of other things. So we're being very cautious. We could also reinitiate treatment. So one of the biggest challenges in the public sector is when they have a stock out and a patient spends money to get to the clinic and they're out of stock, they stop treatment. And now there's an opportunity to get those people back onto ART. You may also have somebody, which is, and Jan, you can attest to this, where we started supplying family planning to state patients in the Deep South. I was at Sun Valley Pharmacy near Fischhoek. And the staff that work at, for instance, the Pick and Pay and some of the other big corporate supermarkets, they cannot afford to take a day off to go to the clinic. And so they would come and get free medicine, but they would pay a consultation fee. So they paid 50 Rand to come and get their medicine from us. And for them, that is cheaper than going to the clinic. We all know that if you take a day off work, it's either out of your leave or it's unpaid. They also have to pay for transport. And in fact, there's a study that shows that to collect your free medicine from a government facility costs almost 200 Rand. So it's not free. So 50 Rand for oral contraceptives or an injectable is a bargain. Then we added on EPI at 95 to 105 Rand. And let me tell you, they are coming to us. And what that does is for those patients that do not have any cash, they're unemployed, they can now go to the clinic and it's not overburdened. So everybody wins. So in conclusion, community pharmacists, I believe, are ideally placed to provide HIV prevention and treatment services. The regulatory environment is enabling. The South African Nursing Council has already supported NIMART for their nurses. We have the expertise, the human resources, the facilities, and we are willing to assist the government. The 1990 targets are within our reach. And guys, the training is going to be starting in February next year. So please spread the word. We need PIMART. We need pharmacists to be taking this on. We've got 1.2 million patients that we need to test, confirm, and get onto ARVs. And then we've got 200,000 patients that we need to get onto PrEP. So let's do this together. Thank you.